3, 2, 1.
Good afternoon, everybody. We are here at New York, Montefiore, Einstein, and Montefiore with our cardiology program presentations and lecture. It's my pleasure and honor today to introduce Dr. Briceno. Dr. Briceno did his medical school in Colombia, Cali. And then he successfully moved to US, where he did his internal medicine studies in Texas, in the Houston area, the Methodist Hospital. Then he joined Montefiore here for his cardiology fellowship. And I have to say, he started collaborating with me since then. He has been a great fellow and a great friend now. Then he went to do his EP fellowship at the prestigious UPenn University, published a lot of paper within this program and the UPenn program, and joined back Montefiore about a couple of years ago, and it's my pleasure to work with him. He's in charge for us of the hypertrophic cardiomyopathy program. All of you knows that hypertrophic cardiomyopathy is a very unique disease that require the attention of many cardiologists of different area, but you need to be concentrated and have a program. We are happy to have one program here, and David is leading it, and we are happy that he can coordinate these patients for the hospital, and we are here to listen to his presentation that I'm sure will be super successful.
Welcome to Zoom. Enter your meeting ID.
Okay, perfect. Thank you so much, Dr. DiBiase. Thank you so much, Dr. Garcia, for the invitation to give
Enter
this
your participant ID.
this presentation of hypertrophic cardiomyopathy. And yeah, I was given the lead earlier this year by Dr. Garcia to go ahead and lead the hypertrophic cardiomyopathy program. It's been a real honor just to try to put together so many decades of experience of this institution of treating these complex patients. But it's a real honor to try to put together all these years of experience from the surgical side, from the advanced heart failure side, and from the arrhythmia perspective to try to put something together. Right now, the best year to start a program, but I'm positive that with everything that is going on here, we should become a center of excellence in the next couple of years. So yeah, I'm going to start with an overview of this fascinating disease. I don't have any disclosures to report, other than probably I'm just starting to gain experience on this fascinating field. So these are the objectives for now. We're going to talk a little bit about the history, epidemiology, diagnostic criteria, basic genetics. And the genetics part is really fascinating. It's a little bit beyond my scope, but we'll try to approach some basic genetics and see how this can help with family screening and risk stratification. And then we'll go over clinical manifestations and finalize with differential diagnosis. So in terms of history, so this was described now almost 70 years ago in London by Dr. Tier. It's at St. George Hospital, and it's really fascinating, just based essentially from a case report or a small or very small case series. It started describing very accurately what we still are working through today, which, as you can see here in figure 1, he's describing a localized, do you guys see my mouse as I move it?
Yes.
Okay, perfect. You guys can see here localized hypertrophy of the septum. And then histology-wise, he describe disorganized and disorder arrangement from the muscle bundles, even went ahead and described abnormalities in the mitral valve, and ultimately showed already fibrosis. So this is all what we still are trying to understand and taking it from there. But he's the one that first described it back in the 50s. So this is essentially a pathophysiological substrate. Okay, it's a sarcomere disease. It's a sarcomere disease, and we'll go more into detail about the genetics and everything, but just to put you guys into perspective, here we have the I band, A band, and then, you know, the myosin rods. And the main two problems here are going to be these two. The myosin binding protein is the protein that binds the two myosin rods, okay? Myosin protein binding C. And then this little big guy here, the beta myosin heavy chain. The thin chain, the light chains are these small ones. But the major features of the disease will be sarcomeric with the beta myosin heavy chain and the myosin binding protein C. And this is, again, putting more into an updated histologic view, you know, what the disease is essentially. And in panel A, we have a normal histology, okay, very nice fibers, homogeneous, with minimal interstitial separation. And essentially the disease in panel B, we can see the disease phenotype, which is essentially disorganized arrays. And if you magnify, you will just see more interstitial fillings, and if you add special stainings, you're going to reveal the fibrosis. And this is what we have characterized in all these years. And this has been, you know, it's interesting because despite being so multisystemic disease and everything, there's especially a single group that have taken the effort of you know, progressing the field, or at least taking the lead of progressing the field in this specific subject, which is the Maron family, you know, father, son, and Dr. Branwell. But then in the 60s, starting having with very basic modes describing the disease, and then in the 70s, M mode, then echo, and then more recently, the MRI has been a real game changer for diagnosis, management, and stratification. And here we can see everything that is being taken. Here a little bit more into perspective. Again, in the 50s, the first case. Then by Kathan, use some more descriptions. Then some, you know, problems in the mitral valve later. More better profile, better profiling in the 80s with the advent of the first wave of MRI. TE better, pacing started coming up, that now is out of flavor, but then, you know, the pacing part came, and eventually came the second wave of MRI. And interestingly, in 2014, it was now mentioned as a treatable disease, okay? And I think we still need to update this to 2020. Actually, this is a special year when we started having results of the specific modifying drugs, modifying specific targeted drugs, not only for symptoms, not only to decrease the gradients like we do with beta blockers and calcium channel blockers, but we started seeing sarcomeric directed drugs. Okay, a little bit of epidemiology. So the big concept of epidemiology is that this is an under-recognized disease, okay? For different reasons, for difficult access to healthcare, for many of the patients are asymptomatic, but listen, it has been described in all the red, okay? So it has been described in 122 countries, which correspond to about 90% of the population. And if we put that down to a prevalence of 200 to 500 per person that have been described, 500 per person just phenotypically. If you do more genetic testing, we'll probably switch it down to the 200 range. You should have at least 20 million people affected worldwide, all right? But then what the reality is this, right, that most of the patients are unidentified, and just a small fraction is that, you know, we know them, and of those, some are symptomatic, some are not. This is more data from the from the US from earlier this year. 105, 1 in 500 prevalence, which is about 650, 100,000. And again, part of the under recognition, okay? Despite being more common than many of these other diseases that get more attention, cystic fibrosis, you know, MS, Brugada, listen, hypertrophic cardiomyopathy, much more prevalent, and still difficulties in with recognition. A little bit of diagnostic criteria. So very recently, updated guidelines came up. They can be found in ACC, AHA, and it's essentially very simple. All right, very simple is, and I just put it directly from the guideline, is any LVH in the absence of any other metabolic disease. And this is tricky because most of these patients have chronic hypertension, but in the absence of a cardiac, systemic, or metabolic disease, causing a degree of hypertrophy that wouldn't be expected otherwise, and that is suspected to be sarcomere related for different reasons. Obviously, the genetic part has a big role in that definition, and it's an imaging-based diagnosis, obviously, with echo, with MRI, and the cutoff is 15 millimeters, or 15 millimeters, and again, is in the absence of any other hypertrophy. Now, some patients are less than 50 millimeter, and then that's when it comes out to see if it wasn't well seen in echo, and then that patient never got an MRI. But by cutoff, if 15, some patients will have less than 15. These are the most common phenotypes that we see. Just to put it here into perspective, these are the septal phenotypes. And then the most common ones are sigmoidal, when you see the little bump on top of the septum, which is very tricky because sometimes, we see that in many people with hypertension, but we have that is one of the most common phenotypes, and it's only 10% gene positive. Now we have the second one, which is the reverse Q, where we see something more, more impressive phenotypes that is more positive genotype, and then we see apical forms, and then more neutral that include the whole septum. And the MRI has helped clarify many things, as I was saying before, particularly with the phenotypic expression. We'll see also later a little bit of the differences. But here, for example, we see a thick septum that was progressing into the RV. Here we see a mid-septal with an apical aneurysm, this is a very, very, very high risk phenotype for sudden cardiac death. I will see that later. We can also detail this that in echo we may not see it, and it's essentially this anterolateral papillary muscle obstruction from the papillary muscle, essentially. So no chordae tendineae, it's only the papillary muscle attached to the valve. This is the surgeons are probably very familiar with these forms, particularly before the MRI era, I suppose. But it's a very interesting phenotype. And then we can also delineate the mitral valve relation to the physiology. Now, the elongated mitral valve is not part of the criteria, but it's important to characterize it, to see what is the contribution to lvot obstruction. But the criteria, remember, is basically the thickness. Here, essentially, thick papillary muscles or prominent papillary muscles. And this one, very interesting as well. It's essentially normal LV, but then it has this posterior inferior thickness with crypts and scar, very, very probably high risk as well. And this is some of the advantages, okay? And I think everyone should get an echo at baseline, obviously, but some of these patients, or many of these patients, or in my practice, all of them get MRI. And this is one of the reasons, you have this anterolateral component that probably was borderline thickness, but then, when reviewing MRI, is a massive cavity or massive thickness. The same with the LV. I mean, we can do contrast, whatnot, but then in MRI, you can see these apical profiles. And this is actually very interesting. The apical profiles, it's very difficult to detail them if it's not with MRI. The same here, a little bit more septal thickening, which is extremely worrisome in MRI. A little bit on basic genetics. So this is just an overview. And by the way, these are reference that I have down here, the AHA Hypertrophic Cardiomyopathy Initiative. It's really, really amazing, and you guys should look it up. It's a series of webinar. I think they have done already 2, but it's really amazing how they go over all this. Anyways, coming back to the basic genetics, so the specific gene mutations do not reliably predict the extent of hypertrophy. We'll see examples of this. They don't necessarily predict the hypertrophy, the clinical course, or the prognosis. Not necessarily or not reliably. And then the utility of genetic testing is probably confined to, screening family members, first degree, identifying some specific phenocopy, and helping to confirm the diagnosis of HCM in ambiguous cases. And that's a very, very good point. Coming back to a little bit of the genetics. So we have 11 genes that cause hypertrophic cardiomyopathy, but then out of those 11, there's more than 1,500 mutations that can cause it. So difficult to understand, what is the implications of so many mutations. But most of them, half of them, are going to be the thick filament, and almost half of them will be gene positive. Okay, and from the thick filament is going to be most of the time, as we said before, the heavy chain and the protein C3. Now, why some, and we'll see this in the next slide, but why some people genotype positive, they never develop a phenotype? Well, because there's a range of problems. It's an autosomal dominant thing, are de novo mutations, that de novo mutations can become with very different genetic characteristics, including by DNA modifications, by microRNA changes, and ultimately environmental factors can play a role in the phenotype manifestation. This is the classical disease with autosomal dominance, variable expressions, and incomplete penetrance. So for variable penetrance, they can have two people with the same gene and not manifest, the phenotype. And the same with the variable expression, same gene, and they can have massive severe LVH, can have very high risk of sudden death, or very low risk of sudden death. And this is just an example. This is the variability in the phenotypic expression. We have the proband here with two kids, exactly the same mutation. Okay, you see on the left normal EKG, no LVH whatsoever. On the right, massive LVH with ripple changes, and you can confirm that with echo. Very nice images, very worrisome, thick, hard, probably scar as well. And then, I don't think we understand so much this part of the risk, but there's very good evidence and very good experience from different centers about the impact of some genotypes and clinical outcomes. So here, for example, in this specific myofilaments, and we'll see here in the end. But when you see freedom for this composite outcome of death, ischemic stroke, progression to heart failure, the positive one will have less events. Will have more events. The myofilament positive will have more events. The negative more free from all those outcomes. The same for systolic dysfunction. The same for restrictive LV filling, and the same. This is very nice actually. The same for when you now spread it, thick, thin, double heterozygous. And this is probably genetics 101 for this, but this is I saw this as a good summary on how to approach the genetics of these patients. So the easy one will be, you have the HCM positive phenotypically, and then genetic testing negative. So then you have to do screening for first degree relatives at close intervals when they're less than 20 years old, but when they're more than 20 years, you can space it to 5 years, and then as needed when symptoms develop. Now, the nice part, if they're positive, you can see what mutation is risky or not in terms of clinical outcome, but it's also going to help with the family. So you can develop screening for first degree relative, and if they're negative for this, they don't need further testing, no further screening, no further. They're done at that point. If they're positive, well, they jump into this box. A little bit on clinical manifestations and management. So these I'm going to focus on the main three categories of phenotypic expression. We know that some patients are symptomatic; those are fine. But then then we have the symptomatics one, and then you have to stratify for risk for everyone for risk. So we're going to talk about sudden death. We're going to talk about heart failure, and then we're going to talk about atrial fibrillation. And these are the percentage of these patients experiencing one of these three pathways. So half of them they're going to be fine, no adverse pathway, just clinical follow-up, and they actually do okay. But then almost half of them will have some sort of heart failure, either obstructive or non-obstructive. Most of them obstructive, and then about 17% atrial fibrillation, and then a minority, which is still very high, sudden death events. So starting with sudden death, and this is the main issue here. Here we have a phenotype with a high risk morphology. Again, mid-septal with an apical aneurysm, full of a scar. And then when we map it in the lab, we see normal voltage. Actually, this is very, very surprising. Normal voltage in the whole ventricle, but then in that apex, representation of a scar that would cause monomorphic VT, VF, and that is the cause of sudden death in these patients. So it's very important to to stratify them. There are different ways to do it. Here we have some criteria in the US. The Europeans have different criteria. Combining everything is probably a good approach, and I would say the major risk criteria are pretty homogeneous everywhere, and that includes family history of sudden death, unexplained syncope, non-sustained VT, especially long episodes, when the LVH is massive, more than 30, apical aneurysm, phenotypes that's often missed actually in the clinical practice. Or at least that's what I've seen occasionally in the last few months that I've been leading the program. Extensive LGE. This is interesting because what is extensive? I don't think there's a specific cutoff. Obviously, the higher, the more risky. Some studies talk about 15%, some about 5%. The reality is that perhaps 1 to 2% that sometimes we see is you have to put more things together. And then in stage ejection fraction, which is less than 50 only. So this is actually very worrisome when they start dropping even mildly depressed LV functions. And then, there's more modifiers. So when you have two of those, or when you have one with modifiers that are response to exercise, age, history of alcohol septal ablation, the degree of outflow tract obstruction, they can come into consideration. So this is again try to see exactly what is at the highest risk, which we talk about, what is intermediate, what is lowest, and again all are there. But the typical course is this: you have a 35-year-old that his brother died suddenly. He was diagnosed. He got an ICD the next year. Did fine for 4 years. Got his generator replaced for some reason only after 4 years. But then at 41, 5 years later, he had this. Normal. Started with monomorphic VT that developed into something very fast, ultimately VF, and he was saved by the ICD. Did fine for another 10 years, then another shock, and then he's there. Over time, the substrate seems to start to progress and ultimately developing this. And these are just some cohorts evaluating up here, adult patients here, young patients, but at least to see how often they're going to use it. So in this cohort of 500 patients, 20% at a mean follow-up of 3 years had appropriate therapies. 20%, that's a lot, which is a 5.5% per year. And obviously for secondary prevention, was driven by secondary prevention. The same for kids and you know and young and adolescents. 19% at 3 years, with a yearly rate of 4%. And then this is how to use the risk. Okay, if you use a risk, it's appropriate. You will save the life. You will save the life of a lot of people. Now, if you stratify someone very low risk, you can be essentially confident that the number of events will be extremely low. So two of these patients, those 0.3 to decline. So they were recommended but declined. One had no risk factors, and one of them was not advised. I mean, they said they're not advised appropriately because of an apical, it was an undiagnosed apical phenotype or apical aneurysm that ultimately got diagnosed after the event, after the sudden death event. And this is just to put it there out, I know for people to think about it, but this is based, these are outcomes free, free composite outcomes from different stratification tools. So on blue, you see the best outcome from the ACC AHA stratification, and then these are European classifications. So what is the indication? Just now going by guideline. So the class 1 is if you're doing secondary prevention. Now it becomes 2A when you see at least one or 1 to 2 of the major indications, and you add non-sustained VT or add extensive scar on MRI, you are in the 2A to B range. Okay, if nothing of this is present, even though someone can be concerned, it's not, it's probably low risk and need to reassess. Talking now a little bit about progressive heart failure, so we can discuss what is the center of therapy for this patient is essentially what we're used to. Good beta blocking dose, good calcium channel blocker dose. Disoparamide has been shown to be excellent. I have rarely used it so far, but typically you can get a very good result by good beta blocker and calcium channel blocker dose. Just remember to titrate to heart rate. Okay, go up, and titrate to heart rate less than 60. And then we have the comparative features of septal reduction therapies. This is from 2004, so dual chamber pacing is there. That we know more by more recent study, we know that there may be a big placebo effect, but then septal myomectomy, septal ablation, alcohol ablation is are good options, particularly surgery. But obviously not everyone. Some of these patients are elderly with comorbidities, so alcohol septal ablation comes to play a role. And more recently, we have seen very interesting results with radiofrequency ablation, even probably better or as good as these other two therapies, with a different risk profile. In the sense that the main problem with these patients is heart block, but with radiofrequency, by mapping the conduction system, this risk can be modified. And these are just phenotypes with very adverse outcomes, and we know dilated phenotypes with low EF, or very massive septums, very long scars. And this one actually had such a big septum that he required a lot of alcohol ablation, and went during the procedure into incessant VF, and that was not able to be stopped. This is just an example of alcohol septal ablation, which is essentially all of these therapies try to reduce the gradient that we can see here. Here is in sinus, no gradient between the LV and the aorta. Here with the typical Brockenborough Brown wall sign after PVC, you see major gradients. This is just an example here. They very tiny, this one, they identify the septal perforator. They highlight it, you know, with their methods, saline, contrast. They highlight it there just to define the area, and ultimately inject the alcohol where this is gone, and then the gradients are gone in this patient. They do well. They do well from, you know, in that sense. And this is just a summary. The goal of all these approaches with surgery, even with medications, some patients do very well with medication. High gradients come and do very well with medications. And the alcohol septal, the alcohol ablation, the goal is essentially to go from this to this. And then this is the clinical importance of LVOT obstruction in HCM. No obstruction. This is freedom from progression to heart failure to stroke. No obstruction, they do well. With obstruction, it becomes a problem. And when we talk about obstruction, we are talking about more than 30% at 30 millimeters of gradient, more a baseline, and more than 50 in exercise. And this is actually a nice one when you see the ones that had no obstruction, the ones that had myomectomy, very similar, versus the one that was non-operated obstruction that had the worst outcomes. And then atrial fibrillation and stroke. So these are the electromechanical changes occurring in the left atrium. So you can see this patient, panel A and C, normal heart, no hypertrophy. And then the voltage map, when we go into the left atrium and do the voltage map, all the purple is healthy, okay? All the purple is healthy. And then you see a scar towards the pulmonary veins, which is expected in patients with no underlying medical diseases. So this is kind of a normal left atrial voltage in comparison to hypertrophic cardiomyopathy. Here we see this phenotype where the voltage map, you start seeing a lot of abnormalities in the posterior wall, in the septum. They have a lot of flutters, and in the left atrial appendage. And what are the mechanisms? And it's all part of the same thing: hypertrophy in the LV, hypertrophy in the LA, increase in the size, fibrosis, atrial pressure. But if you have obstructive sleep apnea, diastolic dysfunction, all that, it doesn't work. There's one caveat, that there's one specific genotype, which is the prkg, that they have the prkg syndrome. Essentially, they have AFib as a primary phenomenon in the setting of hypertrophic cardiomyopathy, and they also have WPW. So that's kind of a little apart, but in general, just for the bread and butter HCM, this is sort of the physiology. And then this rate versus rate control, we're electrophysiologists. We know the bad hemodynamics when they're fast, when they're irregular. So these patients should be on sinus. The evidence of that is not excellent, but sinus rating should be attempted. But the main thing, regardless of what you do, is anticoagulation, and I'll show you why. These are the landmark trials for AFib in hypertrophic cardiomyopathy. Just AFib. We're not talking about here risk of death because of scar, because of a big thick septum, because of family history, because of VT. No, just AFib with no anticoagulation. 3.7 time mortality, 1.5 mortality, 2.5 mortality. Just before I go there, but on anticoagulation, look, there's no difference regardless of what you do. Okay, HCM with AF anticoagulated versus HCM without AF, no difference in all-cause death, no difference in HCM related death, no difference in sudden death events. This is the same, and no difference in HCM related death in paroxysmal versus permanent, as long as you are anticoagulated. Now, the patients with paroxysmal is very interesting because you think all these patients are persistent, but the ones that have paroxysmal, they actually just have a few paroxysmal events, and they start developing when they get older, which is not unexpected either. Just coming back here in terms of anticoagulation versus non-anticoagulation, the same thing. And in terms of heart failure, so no difference. HCM with AF anticoagulated versus HCM without AF anticoagulated. Maybe after 6 to 8 years, maybe they start to you see an effect, but overall no effect. Same here. Obstructive with AF, obstructive without AF, even obstructive phenotypes. The same for non-obstructive. And these are insights from Dr. DiBiase. These are patients that got ablated, extensive ablation, and they have late recurrence. And then some of these patients have, these patients have the veins and the bulk of the first procedure is good, but then they have trigger from the CS, from the append. Half of these patients from the appendage. So probably, so it's a good idea to offer extensive ablations as a first procedure for this patient, depending on the patient profile. And this is where we are today. This is where we are today in terms of mortality. So in the 70s, 6% mortality. Then it started improving to 2%, to 2% per year, 6% per year, 2% per year. And then as we added ICDs, we managed the obstruction, we heart transplantation. That's a fascinating topic. And then the different things. We now are at 0.5 to 0.6 percent mortality per year. Which is lower than just the overall mortality, the US general population mortality, which is 0.8%. So really fascinating how we can change the disease course. And this is just to put again into perspective with other medical problems. This is the current annual mortality of HCM, which is about 0.5 again, compared to other diseases. We're down to 6% in myocardial infarction, but then lung cancer and these rare diseases, more than 15%. Just to summarize the pathways, so we have the HCM population. We have the genetics with no phenotypic, so that's out as different. We have the phenotypes. We remove the ones that have no symptoms or low risk, and then the adverse disease complications. Increase sudden death risk. We know when to put an ICD. We know that if they're low risk, they probably just need conservative management. We know the progressive heart failure profile, drug treatment. Most of them are obstructive. You need to check this at baseline, at exercise. And if needed, try to do reversal therapies, reversal interventional therapies. And then the non-obstructive are challenging. And then we have the atrial fibrillation profile, which these patients need anticoagulation regardless of CHA2DS2-VASc. Now, again, exciting things coming up. We have drug-specific, targeted specific drugs. That essentially, this is a normal sarcomere. We saw it before. This is the bridge with the most common mutation, as we said, the protein C. The protein C, active myosin. This is a phenotype. It's just a lot of hypercontractility. And then we have this drug mavacamten that essentially attenuates this hypercontractility. And here we have a little bit of the pharmacology that essentially inhibits the myosin ATPase. And then there's the recent trial published in Lancet. This is a phase 3 still, but very interesting. It decreased all the primary outcomes, safety concerns, 0, same as placebo, and then it was 10%, but nothing very worrisome. We'll see larger studies, but look at this. This is LVOT gradients, mavacamten, no change in the AF between both. These are resting LVOT gradients. This is about salve LVOT gradients. These are functional classes. Purple class 1 at 14 weeks, at 30 weeks going up from 0. This is placebo. So I think it's exciting things coming up. Always think about differential, okay? And that's why I'm a bit advocate on MRI on many of these patients, on many of these patients, because you need to make sure there's no amyloidosis, which we see frequently here in the Bronx, or other genetic abnormalities that may be a problem. That's why also genetic testing is so important, and we're fortunate here to have an amazing cardiogenetic center that they have all the counseling. They have a very nice approach, and a very nice team taking care of these patients. So we see the clinical side, and then these patients get referred to the cardiogenetic service for further counseling, as is important with every genetic problem. So in summary, most common cardiovascular, hereditary cardiovascular condition, autosomal dominant pattern, so it can be de novo mutations, prevalence 1 in 500 individuals, up to 200 in the with genetic testing, heterogeneous clinical course that we saw, and then currently with what we're doing seems to be doing a good job, with 0.5% mortality per year. Resources, you have them all there. And obviously, the Maron team are a big reference for this. But again, there's the AHA ECC initiatives. Both are really amazing. I'm very impressed with the AHA initiative, with these webinars. They have 3 persons from different parts of the country doing these lectures, and it's a very, very nice overview of everything. Thank you so much.
Thank you very much, David. That was a beautiful and exhaustive and complete presentation on this important topic. So I'm requesting some questions from the people that are following here, and there's one question for you. Can you address the issue with athlete screening and exercise recommendation from Dr. Bradlow?
Yeah, that's Dr. Bradlow. This is a good question as always. This is a very difficult question. I'm not sure about the answer for this. And probably Dr. DiBiase can give us an input from this. Many European places, including Italy, they do this for everyone. In the US, it's a more conservative approach. The reality is that competitive in high risk patients is probably contraindicated. Does that mean that they cannot do exercise? They can probably do moderate, but I think the big message is competitive in high risk is a no. We don't do a screening here for everyone, and I think that's probably okay. But Luigi, do you have any input from the Italian?
No, I think that's a difficult topic. Europeans also take the lead on this. I agree with that, and I think that it's athletes are a different population that require more screening and specialized AKG and cardiac MRI, and I think all these tests should be mandatory, and they are not. And that's the huge difference with Europe. Another question that I have for you is, does alcohol septal ablation favorably influence survival in symptomatic patients?
Alcohol septal influence survival?
Yes, symptomatic patients.
I don't think this has been shown in terms of survival. The key there will be symptoms and improving quality of life. But considering that if it's a successful and the gradients are down, probably it may have an impact on survival.
So for ablation for you, when you do AFib ablation, you clearly show that PVI only doesn't work, and you need to be prepared to, more aggressive ablation. And most of the time, at least 2 procedures are needed. How about VT ablation? I mean, there are some papers there. I actually wrote one of them that recommend endoepicardial ablation from procedure 1. What's your experience at UPenn?
So so that's interesting because this is a population that is very selective, and even at UPenn that we get all the referrals, or they get all the referrals for VT. The numbers of VT ablation in these patients are really minimal. Are minimal, and I suspect it's just because perhaps the substrate on the way the research certification is done is different. But I think an aggressive baseline approach is probably the way to go, as we have shown with ARVC, and as we have shown with all of these non-ischemic cardiomyopathies, where the substrates are most commonly epicardial. Now, if there's an apical aneurysm, okay, there's an apical aneurysm phenotype. So the short answer, I would say, depends on the substrate on the patient. For example, in an apical aneurysm substrate, I'm not sure you need epicardial ablation for those patients, because they do well isolating the apex, the scar from the apex. They do well like that. They may need a second procedure if they have an epi component. But I think, except that, probably based on substrate evaluation, and I think endoepi will be offered to most of these patients.
The new 2020 guidelines for hypertrophic cardiomyopathy are out, as you are aware of. Is there anything that caught your attention that you feel like, oh my God, that's very different than before, or that you feel actually has not been addressed properly?
Interesting. I think the nice thing of these guidelines, it consolidates many of the things that we have seen, or we have studied for so long, including anticoagulation for everyone with AFib, advocating ICD implantation, advocating good stratification and ICD implantation. I think we're still early to know what's going on with the new medications, and I don't think they get addressed in these guidelines.
Okay, so I think I don't see more questions. I'm sure that there are more questions that will come up, but this was recorded. This was a beautiful presentation that allow us to understand that it's one cardiomyopathy, but put together a lot of cardiac subspecialty, from EP to imaging to genetics to general cardiology to management of medication. So these are patients that clearly show that the team approach is the only way to win, and not to exclude the possibility of having a cardiac surgeon doing some myectomy or some intervention to this patient. Something that I discussed with you, David, that it's something new. I've written small protocol, never accepted for funding, is the possibility of trying ablation of this patient, not for the arrhythmias, but ablate the septum. It's something that I still dream as something that could be done in this patient. There are no data out. We need funding to do that, but I encourage you to, as you are an electrophysiologist, to pursue something in this direction.
Yeah, no, I think I totally agree, Luigi. This is very exciting, and the small protocols published, they are very, very good. They're very encouraging. So let's see.
So I wish everybody a good continuation of the day, and We will connect soon again with our Monte channel with the following presentation that will come very soon. We wish you holiday since it's before the Christmas and New Year's Eve. And thank you, David, again.
Thank you so much for assisting everyone. Thank you, Dr. Biasi.
Of any existing ticket, please press 2. For a new, please stay on the line while we connect you to the next available service desk associate. Your call may be monitored for quality assurance purposes.
Good afternoon, this is Sophie. Can I get your last name, please?
Audinot.
First name?
Milagros.
How may I help, Milagros?
So I need your help desperately right now. I was doing a Zoom and
Sure.
Huh?
Sure. What happened with the Zoom?
So I need you to log in so you can see because I can't
Okay, what's your
explain.
computer ID?
WECARC8.
C for Charlie, the number 8.
Yes.
Okay, just need you to click approve once you get the message on your end.
Okay.
Mhm.
Coming.
Okay, let's see. Yep, what's going on?
Okay, so the meeting just finished. However, let me just do this. Let me just do this. I was not able to see or any of the participants. Wait, let me stop this recording. Let's stop that.
Mm-hmm. It's not showing the participants' names.
Wait, hold on. Hold on. Let me just get control.